it's not just a matter of putting in safe practices. We really have to change the culture. And this has turned out to be anything but simple, of course. But I think it's fair to say that we now at least have awareness. I doubt if there's a hospital in America that doesn't recognize that it has a safety problem. It used to be they had a safety problem, but we don't have it here. You don't hear that anymore. Translating that into commitment for action is another matter, but the fact is the first step has been achieved. I think a number have made some success in moving to what we call a just culture. There's a lot of confusion when we first started talking about not punishing for errors, and people say we have to have a no-blame culture. None of us ever said no-blame culture. I don't know really how that phrase got developed. What we said is you should not punish for people for making errors. That's a very different thing from holding people accountable for malfeasance. And so what a just culture is a culture that says we don't punish people for making errors because we know those are the products of faulty systems. But we do hold people accountable and yes, punish, if indicated, if they deliberately violate safe practices. So this balance is very important, and it's not very difficult. It's usually pretty easy to tell the difference between an error and a deliberate violation of a safe practice. And hospitals are beginning to get that. I'm not from Texas. Beginning to get that, and I think are making some progress. Similarly, I think we're seeing more and more interest in team training. There are now firms that go around the country training people in teams, and that's a good thing. And of course, we have today a representative, one of the cardinal, if you will, representatives of patient advocacy groups. You'll hear from Sue, but I think that the patient advocacy groups have made a huge impact in terms of building awareness and commitment in the hospitals. So we're seeing some changes. We'll come back to this later. It's not enough, of course. Similarly, we've begun to make some inroads in the whole issue of disclosure, apology, and compensation. Again, we have in the room Rick Boothman from Michigan, who've been the leaders in showing us how this works. But indeed, their numbers are awesome, and it is metastasizing. We now have the University of Illinois in Chicago, VA, hospitals in California, and other places that are doing this. So we're beginning to get some traction on the whole issue of honest, fair, open disclosure, apology, and compensation. Something that many of you may not have paid much attention to or may not even know anything about is the fact that while we've been working on processes in safety and so forth, the Accreditation Council for Graduate Medical Education and the American Board of Medical Specialties over the last 10 years have devoted a huge amount of effort into defining competence of physicians and specifically laying out the metrics of competence, the various domains of competence. They have identified 6 general areas, both for the purpose of having criteria and measurement for training, but also for recertification and for maintaining competence and certification. This is still a work in process, but it's a crucially important thing in our highly complex and diverse professional experience, and I think it's clearly an important element of patient safety, which really gets almost no attention, so I want to give it some attention right now. We're all impressed, of course, with technology. We love technology. At last, the electronic health record is beginning to get the kind of support it needs. It'll still be another 5 or 10 years before it's where we want it. But finally, we've got the national resources devoted to it that should have been done 10 years previously, and that is clearly going to make a huge difference. I think more progress in many places are the various technological safeguards that have been put in the medication process, barcoding, fusion pumps, robotic dispensing, and so forth, that make a huge difference, getting the human out of the equation to the extent you can to reduce errors. And there's been nothing to compare with the rapid spread of simulation over the last 5 years or so. A very powerful way to teach people not only techniques and processes, but I think even more importantly, teamwork and interpersonal communication. So that these technical advances, I think, have made a huge difference, and we're going to see even more from them in the future. On the regulation and payment side, I made the comment that the regulation is weak and generally ineffective, but a lot of interesting things have happened, as you can see here. More and more states, more than a majority now, require public reporting of serious reportable events. The federal government, after about 5 years delay, finally provided protection for reporting and establishment of patient safety organizations. Now with Medicare and a number of other payers not paying for serious reported events, we're seeing some pressure coming from that area. The Joint Commission has had its program of announcing goals each year for safety. I think one of the most important things they did, frankly, was the unannounced inspection. It's made a huge difference in terms of the way hospitals respond. As far as I can see, very much to the good. That we're not now just getting up for the Joint Commission. We have to maintain our standards all the time.